Welcome, everybody. Thank you for everyone who has been participating thus far in what has been a really terrific and stimulating workshop. The title of the workshop is Lessons Learned from the COVID Pandemic to Improve Diagnosis. My name is Derek Angus. I'm co-chair for the Planning Committee and currently serve at the University of Pittsburgh and UPMC Health System. I'm Executive Vice President and Chief Innovation Officer for UPMC. And I'm pleased to moderate this final session. This final session is entitled A Vision for the Future of Diagnostic Excellence. Now, when we in the Planning Committee were putting this workshop together, we decided we wanted to tackle a fairly narrow ellipse in the Venn diagram between advancing diagnostic excellence and COVID. That should have been somewhat discreet, but has been very obvious throughout the day. It's a huge topic, and a large number of themes have emerged throughout the day. We've had a lot of issues unpacked, but we haven't until now thought about how do we then repackage things to then work out how we carry these themes forward in a vision for the future. Because it is such a big, complex issue, of course, many stakeholders will have different viewpoints, different perspectives. So we could have charged this final session with a huge number of stakeholders. What we've tried to do is pull together a set of speakers or panelists, 4 speakers who represent some of what we think to be some of the most important likely stakeholders. So we have Dr. Preeti Malani, who is an infectious disease doctor and professor of medicine at the Division of Infectious Disease at the University of Michigan, as well as an associate editor at JAMA. And importantly for today also is Chief Health Officer for the University of Michigan. And in one of her roles included advising the Big Ten Athletic Conference on how it should handle itself in the middle of COVID. And would be particularly interested in Preeti's view on how institutions, large institutions, think about diagnostic excellence in the face of pandemics. We also have Nicole, who is actually one of the members of our planning committee, chaired the last session, and as was previously introduced, is the director of the Coalition for Epidemic Preparedness Innovations in the US and strategic advisor and CEO of CEPI, but also has had a prominent role in the federal government in ASPR, and so we'll be particularly interested in her reflecting on the role of the feds, the role of the federal government in thinking about diagnostic excellence. We're also hoping to have join us, I'm not sure if she's signed on yet, but Nicole Alexander-Scott, who's director of the Rhode Island Department of Health, and in that role represents both local government, but also the community that she serves. And we've heard as a theme today about really trying to listen to communities about what communities need. And then finally, we have Dr. Stephen Schachter, who actually is a neurologist, who you wouldn't think necessarily is someone working in the space of COVID, but actually importantly is the Chief Academic Officer for the Consortia for Improving Medicine with Innovation and Technology, as well as Professor of Neurology at Harvard Medical School, and has thought a lot about how you bring together all of the disparate areas of expertise when trying to advance diagnostics. So we're very interested in his perspective. The ground rules for this session are essentially, I'm going to ask each of these speakers to give a short 3 to 4 minute reflection on what they've heard today and their particular take representing their position. And then we're going to essentially move into a prolonged Q&A, more Q&A than in the earlier sessions. And just as before, please feel free to pepper the chat box with some questions. And we're going to stay in this session for about another hour and 10 minutes. So with that, I'd like to ask Preeti to go first.
Thanks, Derek. And thank you for having me, and thank you to the organizers. You know, I have to say this has been a challenging week at the University of Michigan, not in a bad way, but just trying to move forward with essential things while Omicron is surging and people have different concerns. And the last thing that I want to do today was spend the afternoon hearing about COVID, but it's actually been fascinating and very refreshing. So thank you. It's been a really nice way to end a difficult week. So I heard a lot of things today, and I took a few notes. Something I heard from Dr. Rick Bright was sometimes it takes a crisis to drive a paradigm shift. And Derek, your role as a chief innovation officer, and Derek's a good friend of mine, and he's one of the most creative, big thinkers I know. But medicine and healthcare is not very nimble, and I think we do need partnerships with innovators, and we've heard from several of them today. I heard a lot about health equity, and clearly the pandemic has illustrated the large gaps that have been there, but have been sort of laid open in so many ways: access, equity, justice. And these disparities really have been very prominent in terms of who gets COVID, who does poorly with COVID. But health has to go beyond COVID. And I think the diagnostics, as I'm thinking about it, could really be part of addressing health inequities. But a lot has to happen for that to occur. And I was intrigued by Dr. McKee's comments around the UK and maybe what we could learn from them. And the political graph really was astounding to me, that really everyone supported containment, which is really good. I think there's an opportunity for testing to really be part of the way to really address these gaps, but also could be some of the same concerns that could thwart the efforts. I was intrigued to hear about low and middle income countries, and I think HIV is one of the really good paradigms for this. This has been done very well around the country, and it's being done, around the world. It's been done with vaccination as well. I was interested in Dr. Merchant's comments around social media and misinformation and all those risks. I was pleased to hear from a number of people about vulnerable communities, indigenous communities, racial minorities, the Asian community, which has been very hard hit with COVID, not just because of illness. Many are essential workers, but because of the various Asian hate, the actual hate crimes that have occurred and have maybe driven some people out of the healthcare system. Multi-generational homes. One thing I didn't hear was about maybe, and I might have missed it, but more rural communities, people that are unvaccinated and maybe don't want to get tested for COVID. And how do we get there? How do we improve the social desirability? We haven't done it with vaccines. Can we really get to it with testing? The comments around digital equity were also good. Some of my work, Derek, as you know, with the National Poll on Healthy Aging is on older adults. And about half of older adults, 50 to 80, don't use a portal. This tends to be lower income, older age, lower education that predict. And as we were sitting here about an hour ago, there was a New York Times alert that, that you can order tests online and they'll come to your house. But how does that work if you don't use a computer or a smartphone? The supply chain, the need to be nimble, surge capacity, and the things that we've lost on. I also did hear a lot about that connection between testing and health, but what I didn't hear was really how to do it. And I hope we can get into some of that. I've just heard in my own social circles, people unvaccinated who've gotten COVID and then don't have a PCP. And I think that is going to be very difficult. And people have talked about that, but let's really talk about how do you make that happen? Like you get from a positive test to treatment. And I like the idea of thinking of that as an incentive. I know we'll probably talk a little bit about University of Michigan experience later, but I also worry that testing is really being used a lot by people who are vaccinated, boosted, higher income. They're isolating themselves. They're testing to go to a football game or have a party or to keep their kids in school, which are good reasons. But what about people who are maybe more vulnerable and at risk of the kind of things that you and I see clinically? I'll probably stop there. I'm really interested to hear from the others about their reflections as well.
No, that's perfect. And I have a little list of things to come back and ask you questions about if we have time. But